It comes to a point where you actually have to start trusting your son. We as kids, or I'm gonna call ourselves I'm gonna call ourselves kids because parents kids. No matter how old you could be 50, you're still someone's kid. But we as kids trust our parents, so we kind of expect the same kind of trust coming back. I wanted to work. I not just wanted, I did work in a restaurant and I had sickle cell. So it wasn't just my parents. There were also some doctors, family members, friends saying no. Kitchens are a lot of stress, heat, dehydration. It is pretty much a kill zone for anybody with sickle cell. I worked in a kitchen for about a year without no problems whatsoever with sickle cell. It really amazed me the fact, like, once I left the restaurant industry, it really amazed me the fact that I was able to do this with sickle cell and had almost no problems whatsoever. So I say you just have to trust your kid and let them grow up. If they do it and then they find out that it doesn't work or something, no harm done. They get the experience. They know they won't have to live their whole life thinking, what if I did this or what if I did that? Because that's what I'm kind of experiencing right now.
What I would like to add as well, and I'm glad Irvin made that point, what I do tell my parents is let your child decide what they can and cannot do. You should not be the person to tell them, no, you can't do that. They will decide that on their own, whether it's playing sports or a particular occupation, and their disease may limit them from doing something, but it will be their decision. They'll see, well, I can't do this. Well, every time I do this, it causes me this amount of pain, or every time I do this, I end up in the hospital. So this is something I can't do. Let me try something else. But I tell parents, don't you limit your child. Let them decide what they can and cannot do. I think that's the best advice that I can give when it comes to those type of things. And then sometimes the profession may limit them, as well. For people who want to go in the military, they can't go in the military if they have sickle cell disease. So I try to help them to be realistic about what their choices are as well. Say, for instance, construction outside. That's probably not an occupation a patient with sickle cell can do because of the exposure to the elements consistently. But they will eventually find out what they can and cannot do. My best advice is to support them and let them figure it out on their own.
And I think I would echo that in hemophilia. Obviously, there are some limitations in terms of activities that really the risk outweighs the benefit, and we can say that, and we do, but it needs to be an interactive conversation. And so, we don't like to say no. We like to say, well, these are the concerns we have, and how about this as an alternative? And can things be modified to make them more amenable in terms of career choice? Honestly, sometimes what limits opportunity is insurance.
Mm-hmm.
And so, working in a boutique computer firm where there's no insurance really isn't a viable option for somebody with hemophilia, which is a very expensive disorder. Factor concentrates can cost $250,000 a year. And so, but that discussion needs to happen. So there's not a no, there's an explanation and an understanding. So maybe you could work for Apple and fill that need to be creative, but be in a bigger firm where insurance is an option. So I think having an open conversation and providing alternatives is a good approach. In terms of just our transition building programs and this grant, I just wanted to spend some time talking about a little bit about the nuts and bolts of what goes into transition, because we're talking a lot about going from the pediatric center to an adult center, but there are pieces of care that need to be addressed, and Dr. White alluded to these. But that helps build confidence and allows patients and families to make these sort of planned mistakes and address some of those issues. So I know Barbara is a little further along with the transition program in sickle cell. So what are some of the things that you've incorporated in your program?
I've been fortunate enough to have the support and buy-in of Children's Hospital to start an adolescent transition clinic. So we've instituted that so far, that the clinic is now open, that you can make an appointment. What I've decided to do right now is to start with kids, and I know you're adults, but I still say kids as well. at age 18. The best age is between 12 and 13, but because of the volume of patients that we have, I decided to start at 18 because those are the kids that are going to be ready to go. So those that are now between 18 and 21, trying to get them ready to leave for transition. I did do my doctorate in and I'm getting nervous, transitioning adolescents from pediatric to adult care. But what I've started in my practice, and I'm encouraging other providers to do, is as soon as your child can really speak and communicate well, that might be 5 years old, that might be 6 years old, start to help them to be independent. And I tell parents that it's really up to you how your child is going to grow or deal with their disease. Because if you raise them to feel like they can and cannot do things, or to make them feel like they're an invalid, then that's how they're going to grow up. But if you raise them to be more independent or more assertive, then that's how they're going to grow up. So my patients know when they come to me, if they're really able to talk, I tell the parents from the very beginning, I want to talk to your child. And I ask routine questions. What is your name? How old are you? What type of sickle cell do you have? When's the last time you had pain? When's the last time you had fever? What did you do about it? So I stop them very early with that conversation so they know when they come to see me that these are the questions they're going to be asked. And parents will tell you, I'll put my hand up very quickly to say, I want to talk to your child. And then when they become teenagers, I do ask the parent to leave the room. So, because we're finding out that when kids leave us to go to adult care, when we check on them, they are either not alive, they've not attached to a medical home, they're using the emergency room as their primary care. So our goal is to try to prevent that, to truly make sure that they feel that they're ready to start transition. And I'm so happy that Dr. White came up with the core elements of transition, because that's what I will be doing with the transition clinic, doing readiness assessment, making sure that I identify with their child what areas they feel like they need more help on to get them ready to transition. I hope I answered your question, Chris, but
Great.
yeah.
So what we're doing in hemophilia, we're very fortunate that the National Hemophilia Foundation had a multidisciplinary group that developed transition guidelines for patients with bleeding disorders that actually start at birth. And they have a sort of multidisciplinary focus. They identify resources and tools, and we've taken those one step further and actually made what we call an annual review. It's really a quiz, but we don't want to call it a quiz because we don't want to make anybody nervous. But it's 25 questions, multiple choice, a few fill in the blanks. And from time to time, when we're not too slammed doing other things, we try to give patients and parents those tools in the waiting room. And that helps me sort of understand where they are. Do they understand the genetics of hemophilia? Do they know what the signs of a bleed are? Do they know what their insurance is? And I can tailor the discussions during clinic to address those gaps. Now, similar to Barbara, I am usually talking with my patients starting at a very young age. Tell me why you're here today. Do you know why you come to hematology? And I'm always amazed at, hemophilia and von Willebrand's and thrombosis. Those are all pretty big words. And we all know that you develop a whole different vocabulary when you have chronic illness. And so I want to sort of know where they are with that. And we build on it every year. And I have different expectations about, what are the key things to remember at different ages. And the hope is that as the patients are getting older, they are ready for these transitions. And we do have those inevitable planned failures, or we take a step back. And it's not perfect, but we're hoping to develop a more formal transition clinic. But we're not as far along as Barbara is.
Chris, I also wanted to add, I just want to make everybody aware that it's hard for adults, providers, pediatric providers, to let go as well. You form such a close relationship with your patients that it's really hard for us when they leave to go as well. So it's not like we're pushing you out, as Jessica said I did with her, because we didn't have the steps in place when she left, and that tells you how long I've been doing this. But we try to do a better job of preparing them to leave. And I do have a social worker who works with me. She's in the audience, Alexandra Holman. So we're working together to try to do this transition clinic. So there are areas that I might not be as strong on that she is, with insurance and advanced directives and making sure that all of those things are in place. So we just ask that you help us to help your child to be more independent. I know it's hard sometimes for parents to let go as well. And some kids are not as independent as Jessica and Irvin are, and we realize that, and we want to work with your child to get them prepared to leave when it's time. So we just ask that you help us in helping them to be more independent in their care.
And I just want to highlight, and they've done a great job of introducing themselves, but we're fortunate, as I mentioned, that we do have the Hemophilia and Thrombosis Treatment Center network, and we have a great relationship with our adult hematology team. Colleen and Lauren are new members of the team, and they got thrown into the deep end of the pool with the transition project. Dr. Kessler's been with the Adult Treatment Center for longer than I've been here, and I've been here 17 years as the hemophilia nurse coordinator. And our teams are working very well together. We have an algorithm of the steps to help aid transition and logistics like getting the treatment letter to the nurse coordinator so that the schedulers will make the appointment, and then figuring out how to get the two electronic medical record systems to talk. And that's a moving target. So we had transition at Georgetown. So the way that the nurse coordinator, I almost said old nurse coordinator, but the way that the previous nurse coordinator did things is probably a little different. So as providers, I think we have to be flexible about what's going to work now. And as we transition to a new electronic medical record, how's that going to impact on these things? So it is, we appreciate your understanding that this, we hover. I hover. I'm a helicopter nurse coordinator. But I want to enable my patients and families to navigate this process and make it easier. And sometimes that requires me to take a step back and realize that, I need to let go of things. And, as a parent myself, I know that that's hard for you to do for your kids, and for kids, that struggle between wanting independence, but also being a little intimidated by it, I think they're all reasonable concerns. And so I think it speaks volumes that you're all here today and that we're all going through this process together.
Um, so I have two boys. So I was pregnant, and each time I was pregnant, I couldn't take my medication because obviously it affects the baby. So during that time, I realized how important it was for me to take it because I had more crises during those times. So that for me was an eye opener on these medications actually go a long way. And they actually hindered going through not taking the medication hindered me doing day-to-day stuff that I never realized how big of an impact it actually had. So the pregnancy just shed light on me on realizing that I actually do need them to be able to be normal, right? We want to be normal. And taking the medication made me it is normal for me. So I just had to realize that. And obviously I don't know, maybe they have to go through something to make them realize that this is just the way it is. And until they accept that, it's when you'll be able to not be the warden anymore, and they'll be realizing that they're just helping themselves.
Jessica, can you tell them what that medication is?
Oh, hydroxyurea.
Mm. Yeah, for me, it's pretty much the same thing. It comes down to a question of, do you want to live and do you want to live normally? That is the difference between taking the medicine and not. Me, I take hydroxyurea and folic acid, and I'm not gonna go and say like you should take it every day and all that, because I'm gonna be quite honest with you, I forget. I'm not the I'm gonna say I'm not the most brightest person when it comes to things like that. I forget to take my medicine a lot. I get yelled at it, all of that stuff. And then once that happens, I end up getting sick. Which is the obvious. It's what's gonna happen when you don't take your medicine. You're gonna get sick. When I do take my medicine, I'm like normal. I'm pretty much like any other person my age. And it just comes down to, do I want to live comfortably, or do I want to live stressed out, in pain, in a hospital, missing out work, missing out school, grades falling, all of that stuff. So it's just 20 seconds, 10 seconds, take your medicine, or a week in a hospital and a few days recovering. Your choice.
Thank you.
Like the same for our hemophilia patients. If they're missing their factor, then they have bleeds, and there are consequences. And
Me. I just obviously I got very involved in my insurance and my health at a very young age. So I jumped from insurance to insurance to be able to find one that fit me best. And once I got employed at 18, I knew what type of insurance I needed to make sure I had a either no deductible to low deductible. I needed to make sure that there were no insurance barriers in regards to the medications, from generic to brand. The quantity I can take, was it 90-day versus 30-day, which was more cost effective. But that's because I had help with Barbara, or I went through it myself. And I think that when you are looking into that, you have to see all your past experiences. You have an idea of how much an admissions costs, and see what goes in it, but you have to do the deductive work, or you can actually call the insurance beforehand and say, I have this X disease and this is what I need. What do you cover? What is your copay? So you can call them ahead of time and try to figure that out before and see which one fits for you.
So I think in order to feel like I was comfortable in the adult center at Georgetown, I found that it was very helpful to participate in a lot of the additional programming, whether it was the men's group or utilizing the social worker, and finding the communication and just camaraderie that came through those different settings was very helpful in sharing anecdotal experiences that can also be impactful in my own life. In terms of insurance, I think a lot has changed, though. It's not so much critical to the type of employer or the size. I think a lot depends on the state you're in. So if you're going to go to California, there might be some options out there that the state offers. I know for bleeding disorders, there's a genetically handicapped persons program that you can qualify, guarantee issue coverage. Basically, it's just if you have the condition that is a qualifying event. I found I pursued a career in government for a long time just because of the insurance purposes, and I thought that that was going to be the answer. And I think that now that the Affordable Care Act has passed, we found a lot of alternatives. So I guess government is not only the only option, although it's a good one. I think that a lot comes down to the state you're in, and also the generosity of your employer, whether it's a small or large group. I guess we do have additional options that make it much easier to have a career that might be a small business or an entrepreneurial type you know career endeavor. So I guess those are just important considerations for that I've experienced in trying to have some normalcy in my life. And I don't know if it's ever normal. I think my life has just become normalized when I take the medications, when I can prevent bleeding episodes and hopefully preserve my joints over the long term, because I think that that's really, now that I have two kids and trying to lift those kids, it's harder every day. But having good joints to do that is one of the key pieces. So maintaining adherence to regimens and trying to maintain your doctor's visits and do all of that is a critical piece. So thank you.
thank you. And I think you speak to the value of being plugged in, and really going beyond just advocating, but looking for opportunities. Miriam hopes that her boys will stay involved in the community, and I think that is a good way. As parents, if you lose that direct connection with going to those healthcare visits, you can sort of stay plugged in, and it does model that behavior. For when they become adults, and maybe when they're in college and young adults, they won't necessarily do it as often, but they may well come back to it. And so I think as parents coming to meetings like this, talking about the things we talked about today on an ongoing basis will send the message that this is a normal, albeit uncomfortable, part of growing up. And while we're focusing on our kids with healthcare, with chronic healthcare needs, this is a reality for all of our children. And so I think it behooves us to really work with Dr. White and Dr. Barber, Dr. Tuckman, and Dr. Dean to make this a navigable system. And it really starts with making it more of the norm to transition healthcare. So I think we've had big steps today, and I want to thank everybody for coming. Are there other questions, concerns, comments?
See, as a emergency medical provider, any information in an emergency situation is vital. Especially if you don't have a tag, or if you're not comfortable wearing a medical alert, maybe have a pin, or I don't know, maybe a medical alert that says I have more information on my phone. Because when we roll up to a situation in an ambulance, we're going to assume that you have no prior health problems, and then we're going to treat the immediate problems. But if you have a bleeding disorder or sickle cell, then that would explain why you're treating or you're acting that way. That's not normal per se. And me having a bleeding disorder and working as an EMT, I'm going to be paying attention to more of those things than other people would, because I know what it's like and I know what to look for, because I wear a medical alert. And so I know what they look like, and I know where they are. I know they can be on backpacks, on shoes. And now that if you don't, yeah, like I said, any information is vital, especially as an emergency provider.
Thank you. And Dr. Kessler kind of talked about the medical alert bracelet, but my son, what he has are dog tags. So if it's something like you just feel like it'll cramp your style, they look for them because they come in all kinds of different styles, and you can get something that's not going to do that. Yeah, they come at nice beaded bracelets and necklaces too, for a more feminine look.
But I just also suggested for runners, if these little tags that they can wear around their ankles or their wrists, and they're reflective, and you can just have some medical information on that for patients that don't want to wear the true bracelets. Even if they won't wear it during the day, if they'll go out running or go to work, if they'll just put it on, so you can look at their ankles as well. Sometimes they put it on their running shoes, and those are really easily obtained. I'm amazed that people have the tags for their animals, for their pets, but they don't have it for themselves. Actually, you can. Well, I can find out the name, but you can. A lot of Runners World. You go to running shops. Road ID. That's it exactly.
So it's
Right,
Road ID.
Road ID.
Okay. All right.
Thank you. So what do you put on his med alert? Because sickle cell is not his issue.
Mm-hmm.
Like, I don't want you to give him blood and give him the wrong blood.
Mm-hmm.
If you transfuse him, he has a lot of antibodies. So that can do more harm than the sickle cell. The history of strokes is really the big issue, more so than just having sickle cell. So I guess with a case like him, if you know that he has sickle cell, that's one thing. But the big thing that I'm always concerned about is transfusion. Like, if he is in an accident, you just can't give him his blood type. And once we transition, there's no Dr. Lubin.
You can put that on there, though. Yeah, and you can actually list the antibodies on the bracelet as well. Mm-hmm.
And the nice thing in terms of blood banks is, my understanding is that they do track the antibodies, and obviously that would be something to make sure that your son can articulate. If when he's transitioning, obviously in an emergency, we need the medical alert to point somebody in that direction.
Right.
So if there's nothing else, I think we have lunch available for everybody in the cafeteria, and we have some goodie bags that have the transition checklist from gottransition.org, an emergency care plan that you can use as a tool to prepare for unforeseen circumstances. And then there's also a sort of feedback checklist, and I think that is something that as a pediatric provider, I'm very interested in, and Barbara's formalized it in terms of getting feedback from her patients when they've gone to adult care. But I think that's something that I would like to have an ongoing conversation about. How did it go? What did I do well? Where can we improve? So keeping the dialogue open after you transition is going to help us improve on the process for the next generation of patients and families that are transitioning. So those resources are there. They're also on the website. Also in there is a little hot and cool pack. Our patients with hemophilia would use it for ice. Our patients with sickle cell could make it into a heat pack, and a little pen. So I really appreciate everyone coming out. We are hopefully going to have this videotaped, and so this may be available as a resource for patients and families that couldn't be here today. And so we really appreciate you making it a living, breathing conference. And please keep in touch with us and let us know how this helped or how we could improve it for the future, because we value your input.